All right. So I'd like to welcome you to Columbia Ethics Grand Rounds. I'm Sandra Sujin Lee, Professor of Medical Humanities and Ethics and Chief of the Division of Ethics here at Columbia. And I'm absolutely delighted to welcome you to today's Grand Rounds entitled Navigating the Ethical Landscape of Medical Aid in Dying, Emerging Challenges and Future Directions. For those of you new to Ethics Grand Rounds, this is a monthly series organized by the Division of Ethics in the Department of Medical Humanities and Ethics at VPNS here at Columbia. The goal of Ethics Grand Rounds is to engage our community of health professionals, scholars, scientists, and trainees across career stages and disciplines by centering important topics and debates in medical ethics that relate to clinical practice, research, and education. Our hope is that attendees will leave each session with a greater understanding of the ethical and social implications of the topics we discuss. This series is the result of the efforts of our organizing committee, co-led by Assistant Professor Lucas Matthews in our department, and made up of faculty-affiliated ethics division faculty, as well as research and program staff. And their dedication I'm extremely grateful for. So before I turn to our topic for today, I'd like to remind our audience online to please check the chat for logistics and other information for this session. Today's session is going to be recorded and will be uploaded as a resource to the Columbia Division of Ethics website following the event. You will get an email with a link that will provide you with this recording. So today we turn our attention to an ethically complex and contested topic in clinical medicine, medical assistance in dying, or MAiD. While legal in 11 US jurisdictions and under consideration in nearly 20, MAiD remains the subject of intense ethical debate, both in academic literature as well as public discourse. At the heart of these discussions lies the tension between autonomy and belief in the sanctity of life. Advocates argue that MAiD upholds patient self-determination, allowing individuals to make informed choices about their own death. Opponents, however, raise concern that it may compromise a fundamental ethical duty of medicine to heal and protect life. This raises critical questions. What are the ethical limits of patient autonomy? Does permitting MAiD erode the moral foundation of medical practice? Another central concern is the protection of vulnerable populations and how we ensure that MAiD remains a truly voluntary choice rather than a decision shaped by social and economic constraints. Some fear that individuals with disabilities, older adults, or those with limited access to quality palliative care may feel pressured to seek MAiD, not out of personal conviction, but out of a sense of burden to their families or society. Are existing safeguards adequate to protect from coercion and protect those potentially at risk? This is further complicated by the expansion of MAiD's eligibility criteria. While originally framed as an option for terminally ill patients experiencing unbearable suffering, some jurisdictions have extended eligibility to individuals with non-terminal conditions, including severe mental illnesses. These raise ethical questions, such as whether MAiD should be available to those who suffer from psychiatric conditions without a terminal diagnosis. And if so, can we reliably assess decisional capacity in such cases, or does expanding eligibility raise unacceptable risks of wrongful death? Furthermore, and relatedly, ethical challenge concerns involve the role of medical institutions. Some hospitals and healthcare systems prohibit their providers from participating in MAiD, and some clinicians cite professional ethics, religious affiliations, and/or raise conscientious objections. Yet these restrictions may create barriers to equitable access and leave patients with fewer options at the end of life. Do institutional policies restricting MAiD participation unjustly infringe on patient autonomy and the possibility of exacerbating healthcare disparities? And finally, we must ask, are our safeguards strong enough? Jurisdictions where MAiD is legal, eligibility assessments vary and oversight mechanisms differ. Some fear that the gradual expansion of MAiD could lead to a slippery slope where eligibility criteria continue to broaden without sufficient ethical and medical scrutiny and oversight. So how do we balance compassion and autonomy with the responsibility to prevent harm? Now, these are not theoretical questions. As an academic medical center, it is imperative that we engage with these issues thoughtfully, drawing on ethical principles, empirical evidence, and diverse perspectives to navigate this evolving landscape responsibly. We're fortunate to explore these pressing questions and having Yvette Vieira sharing her experience and presenting today. Ms. Vieira is a senior manager of palliative care and healthcare ethics across Atlantic Health System in New Jersey. She sits on the Medical Society of New Jersey's Bioethics Committee, is a board member of New Jersey's Death with Dignity and the Goals of Care Coalition of New Jersey. She is a consultation ethicist to the Academy for Aid in Dying Medicine and serves as an adjunct professor to Drew University's Graduate Medical and Health Humanities program. She is nationally certified by the American Society for Bioethics and Humanities as a healthcare ethics consultant and is currently pursuing her doctorate in medical and health humanities with a focus on public health palliative care initiatives. And it's my pleasure to welcome her for her presentation.
Thank you so much. I feel like you've covered everything. I'm very happy to explore some of these issues with you and some of the controversies around it, some of the questions that we do get, and how this really does play out in real life. So I should also say that I do manage a medical aid in dying program. So I have a lot of experience over the last 5.5 years of meeting these patients, their loved ones, working with physicians and with professionals who are involved in this. So today we're going to talk about a couple of cases that are really of interest. And I think it helps to explore some of the concepts that were just introduced to us. First off, disclosure, any views that I share today are entirely my own and do not represent any of the organizations that I work with. But before we get into this, let's just do a brief overview of the US landscape and the law. So this law has been in effect in the US from 1998. Oregon was the first state that really did bring this legislation through. Since then, we now have 11 jurisdictions that have this law in place. Montana sort of stands out a little bit because the law that is there is actually something that's enshrined in their constitution as a right. So it was not necessarily a law that was passed. And just coincidentally, there is challenges that is being done to that law right now. So that is an interesting event that is occurring over the last couple of weeks. But if we're looking at eligibility, this is something that's really important that we have to have a very strong hold on. There are specific eligibility criteria. First off, the person must be an adult resident of X state. Now, in Oregon and Vermont, these residency requirements no longer apply, so people out of state can go to them to actually get MAiD. They must have a prognosis of 6 months or less to live, and that is done by 2 providers. For the majority of the states, this means 2 physicians. But again, there are states who have started to include APNs as part of that process. But 2 independent providers must qualify that these patients have a terminal diagnosis 6 months or less. They must be mentally capable of making their own decision so that they understand the repercussions of what they're asking for and are fully aware of the pros and cons. acting voluntarily. So again, we don't want to make sure that they are not subject to any influence or coercion to actually make these decisions. And most importantly, they must be capable of self-administering the medication. And what that generally means is that they must be able to swallow about 2 ounces of fluid. There are other routes that the patient can self-administer, but generally it is through the GI tract. So it could be depressing a plunger on a PEG tube or depressing a plunger again on a rectal catheter that it's delivering the medication. But the patient themselves must be physically delivering the medication into their body. So those are the eligibility criteria. The demographics of the patients that use this are really important, and this has not changed over the 25 plus years that we've seen this across the US. Generally, these are patients who are in their mid-70s. It's an equal distribution of male to female. The majority of them are white, very well educated, usually with postgraduate degrees, and very well financed. And this is pretty consistent across all of the states, across all of the jurisdictions, and across the 25 years that we have had this experience in this country. Before we get into the cases, I think it's really important that we understand that there are multiple aspects to medical aid in dying. Definitely, we have the legal aspect. We know that this is a law. There are definite criteria that patients must adhere to and meet in order to participate. There is the medical element, and that is, identifying that this patient both has decisional capacity as well as meeting that requirement for that prognosis of 6 months or less. And then overlapped all of this issues that we are discussing today. So as we go through these cases, I'm going to touch on the legal and medical just a little bit, not to get into it in too much detail. And then I'm going to try to wrap it up with some of the ethical issues that we're exploring here. And there is no right or wrong answer, although I would say I feel that there's a right answer. But my job here today is not to convince you if you're on one end of the spectrum or not, but just to help elucidate some of these issues around medical aid in dying. Now, these first 2 cases that I'm going to talk about are cases that I feel really push the conceptualization of those eligibility criteria. And these are rare cases. I have consulted on these through the National Academy, and these are not happening very frequently, but I think that they're cases that we need to be concerned about and be looking at. So the first one is talking about a bridge to MAiD eligibility. So again, we have those criterias. This is the case of a woman who is using voluntary stopping eating and drinking in order to qualify for MAiD. So this is a patient. Her name is Susan. She's a 63-year-old female. She suffers from chronic diarrhea following a successful resection of colorectal cancer. Despite the cure, her unremitting symptoms have severely impacted her quality of life, leading her to request medical aid in dying. She believes that by voluntarily stopping eating and drinking, she would become terminal and thus qualify for MAiD. So this bridge is a way of helping to meet those criteria so that this patient can participate. Generally, this would be considered for someone who has a non-terminal condition. So they have to create the right conditions to be considered terminal. So legally, let's just take a look at the criteria here. This patient is not currently terminally ill. She does not have a prognosis of 6 months or less to live by 2 physicians. The other criteria she may meet, but these 2 critical ones she is not meeting at this point. Thus, she's using the option of VSED. But VSED itself is a fairly difficult process to go through. It is legal if a patient has decisional capacity, and it is always an option for patients. Often, patients are individuals who have a lot of suffering, unremitting suffering. So it is something that they can legally do, but it is a process that is quite difficult. And the timing of VSED as a bridge to MAiD is going to be a little bit challenging as well. Because for most of these states, there's a 15-day waiting period between the first visit, last visit, and actually accessing the medication. So you have to consider what does that timing look like to get to start the process of VSED. to get to the point where perhaps you are now considered terminally ill, you've done enough damage that you have a prognosis of 6 months or less, but you still may have to wait 15 days between your first visit and your final visit to get the medication. So timing is going to be critical for this patient. And in 2 of our states, in California and New Mexico, they actually have a shorter waiting period. They have 48 hours. So for a patient who really wants to pursue this, those would be the states that perhaps it would work best in, because you don't have to wait the 15 days. And then the question of decision-making capacity comes up. And again, this is the physician or the APN who's evaluating decisional capacity. That patient may have decisional capacity when they engaged with VSED. They may have had capacity all the way along, but are we sure that by the time that they are terminal and they have not taken nutrition or hydration, do they still have capacity to understand what they're asking for? So ethically, many challenges here. Again, autonomy, is sort of the primary principle that we talk about when we refer to MAiD. And, this is a patient who has decided that she wants to end her life, which she feels is really a lot of suffering. So can we equate VSED with the refusal of life-sustaining treatment? We all know that a patient has the option to refuse life-sustaining treatment, but is VSED equivalent to that? We're not removing technology, we're not removing an apparatus or a treatment, but the patient is voluntarily stopping eating and drinking. So is autonomy here really still able to be applied to this patient? And I would say yes. Suffering is the other issue that we talk about quite a bit with medical aid and dying. But interestingly, none of the laws across the US include suffering as a criteria, nor do they include suffering in the body of the law itself, the language that's there. So is suffering something that we should be considering? Should it be used as a qualifier? And it is used as a qualifier in other countries, but not here in the US. And my response to that is, who is judging the suffering? Has the patient suffered enough to be able to qualify for medical aid and dying, or has she not? And if it is a quality of life issue, who is evaluating the quality of life to say that, yes, you have suffered enough, and therefore we grant you this ability to participate in MAiD? So suffering's an interesting one, not in any of the language of the law, but it definitely does come into play as far as how that provider or that physician or APN really responds to those requests. A means to an end. MAiD was intended for patients who have that terminal diagnosis, that have that 6-month prognosis. And is VSED just a loophole for that patient to be able to access MAiD? Is it, in fact, a disingenuous use of medical aid and dying, or is it legitimate? And if you are pursuing VSED, you can pursue VSED all the way through to your death. So why is this patient then transitioning to medical aid and dying? And there's lots of reasons why they may be or why they shouldn't, but it does force us to question if a patient or an individual has a non-terminal illness, should all of them be able to pursue VSED to get to that terminal state to therefore then qualify for MAiD? And it's a question to ask, because that's where the slippery slope starts to come in. Social responsibility is also another ethical issue that I think we need to think about. Has this patient been provided, adequate social supports, adequate medical services to really help maximize the quality of her life? Or is this, again, a response to an inability to access resources to really get relief from the suffering that she is currently enduring? And what is our responsibility as a society to help prepare patients or prepare individuals to have those options? And then the last question, which is a huge question with medical aid and dying, and a lot of people do debate this: is this suicide or is this medical aid and dying? And this is really going to depend quite a bit on how you define suicide versus how you define aid and dying. And how do we differentiate between the two? Now, we know with medical aid and dying, these patients are terminally ill. Their death is imminent, and this is providing them with an option of how and when they would die. It's very often used as an insurance policy. But for patients who do have it, they do have the ability to choose how and when they die. Suicide, you're not necessarily terminal. Absolutely, there may be suffering, but you're not necessarily terminal. And, if you ask patients who are pursuing aid in dying, if you had the opportunity to live, to survive this illness, is that what you would want? And they all answer yes. They do want to live, but they know that they can't and that they won't. And this is how aid in dying becomes an attractive and viable option for them. So suicide is really a huge issue. We could probably talk about this for an entire term, but I do bring it up here because I think it's important to note. So the second category and the second case that I want to bring up is regarding psychiatric diagnosis. And again, this is one of those very, very difficult cases that requires a lot of thoughtful deliberation. You may or may not have read in popular media just a couple of years ago about a case of an anorexic woman who was provided access to aid in dying and utilized it to end her life. So let me tell you a little bit about this case. Just want to make sure I get all the details correct here. So this patient, her name is Jane. She's a 32-year-old woman with a decade-long battle against anorexia nervosa. She's requested aid in dying from her palliative care physician after multiple unsuccessful treatments. Her eating disorder physician and a consultant psychiatrist have determined that she should be considered terminally ill and that she has the decisional capacity to make this request. Jane has not exhausted all of her treatment options for her condition, including the gold standard, which is an intensive inpatient program. She's supported by her family and she's been enrolled in hospice care. She approaches her palliative physician, who is also a MAiD provider, to enroll in the program. However, he's uncomfortable with it. He's not sure that this is the right thing to do. Therefore, he comes to the academy to get a consultation to really understand what his options are. So again, let's take a look at the legal aspects of this case. These are the criteria. These are the criteria that we're not sure this patient is meeting. Is she terminally ill? Does she have that prognosis of 6 months or less? And is she mentally capable of making her own healthcare decisions? Medically, there's the question of terminality. Anorexia nervosa, we know, has a very high mortality rate amongst psychiatric illnesses, but we also know that 79% of patients will make at least a partial recovery. About 21% of patients will make a full recovery from it, but there is a small percentage of patients that will die as a result of this diagnosis. But is that defined? Is that in the literature? Is that something that is clearly, a provider can say, yes, you have reached this point where you are now terminal? Or is it always potentially reversible? Decisional capacity is going to be a really big issue here as well. We are talking about people who have a diagnosed psychiatric illness. So at some point, some of their thinking is impaired. But is their thinking impaired in relation to this decision? And are we concerned that with a BMI of less than 15, that they might not have the ability to really understand fully what they are asking for? And then the other question that comes up with this case is alternative treatment options. This patient has not exhausted all of her options. She has not pursued that sort of gold standard of treatment, which is the intensive inpatient program. And so can we comfortably say aid in dying should be an accessible resource to you when you have not exhausted all of your options? Ethically, again, many, many challenges. Autonomy comes number one. Does this patient understand what she's asking for? Is this self-determination? She's been living with this condition for 10 years. She's been in and out of different treatment facilities, but never the gold standard. And does she have decisional capacity in this regard? Slippery slope. I never like to use slippery slope as an argument because I think for the most part, it just doesn't hold weight. But under these conditions, I do think that there's something to be said for this. If we are going to start considering psychiatric diagnoses that may have a mortality factor to it, who is to say that we wouldn't consider other psychiatric diagnoses? And how are we determining the capacity of these individuals to really understand what they're asking for and the repercussions of it? So the slippery slope here, I think, may have some grounding in this argument. And if you did follow this case, this patient did pursue MAiD. She did actually access it. And the physician who was involved with it did publish quite widely, but then also started to backtrack a little bit about a year later when there was a lot of pushback from the psychiatric community. Suffering comes into play here again. Nothing in the literature about this, but how are we influenced by this patient's suffering? Because undoubtedly she is suffering. And should we be influenced, or should that provider be influenced by it to help qualify her for aid and dying? And is quality of life something that we can truly evaluate when it belongs to someone else? The duty to protect, again, a social responsibility. In behavioral health and psychiatry, there is a strong imperative to prevent suicide, to preserve life. And so are we allowing, or is this patient who has anorexia, by allowing her to pursue aid and dying, are we not preventing suicide? Is this suicide? Are we preserving life? Or are we relieving suffering, which we do understand is a very valuable component of this? So the duty to protect and the contrast between, again, that concept of suicide versus aid and dying does come into play here. And again, we're sort of forced to think about that. And then justice again. Should this patient be required to go through this gold standard treatment? Should they have to be involved in that inpatient intensive program? And do we do this to other patients who have cancer or who have heart disease, that they must pursue all options before aid and dying is an option for them? And we would say no, they have the choice between whether they want to pursue that sort of treatment or not. So why are we thinking that this patient should have to do the same thing? Again, it raises the question of where do we stand on this and how are we viewing this patient different from others? And again, society's support system. Have we failed somewhere to be able to provide this patient with the supports that she needs to improve her quality of life, or to at least be functional in life and have that partial recovery? Or is medical aid in dying just something that is maybe an opportunity for her to put an end to the suffering? So justice really does come into play here. Those first two cases were really about two very specific circumstances, very, very rare. We do not see that very often. And there are ethical issues, absolutely, that are just sort of rampant through both of those cases. But in my mind, this last case is probably the most prevalent and the most destructive for patients. And this is really about access and equity for individuals. And it really talks about the barriers for individuals who qualify to be able to access MAiD. So this gentleman here is, and this is actually one of the cases that I actually worked with. His name is Tom Smith, and I just want to make sure I get all the details right. He's a 72-year-old male with end-stage renal disease and has been on hospice for the last 3 months. With limited finances and no viable treatment options left, Tom's quality of life has significantly deteriorated. He experiences constant pain and fatigue, leading him to seek medical aid in dying as a means to end his suffering. Again, suffering. After 2 months of searching, Tom finally finds a physician willing to assist him with MAiD. He undergoes the necessary consultations and evaluations, and eventually he picks up the prescribed medication. Tom feels a sense of relief, knowing that he has control over his end-of-life decision. However, 2 days before he's scheduled to self-ingest the medication, Tom inadvertently mentions his plan to his hospice nurse, during a routine visit. The nurse is shocked, remains silent, unsure of how to respond later that day. Later that day, Tom receives a call from the hospice administration informing him that he has been discharged from their service. Tom is told that if he proceeds with taking the medical aid and dying medication, he will be required to call 911 to get his body pronounced. And this unexpected turn of events leaves Tom feeling abandoned and uncertain about his next steps. He grapples with the emotional and ethical implications of his decision, now complicated by the loss of his hospice support. There are many barriers that patients experience just trying to access this as an option, and these are for patients who fully qualify. There is stigma that's involved in it. This is very much a dark secret that they do not tell people outside of their inner circle. And so because of that, there is a real stigma involved with it. Poor information or miscommunication or misinformation, a lot of misinformation out there. Many people don't even know that this exists, even in the state of New Jersey, where it's been law for 5.5 years. Many people feel it's illegal, that it doesn't happen in that state. And a lot of patients get this information. Health literacy is also huge here. Being able to access physicians who can actually provide these services, having either the insurance to be able to have those visits or having a lot of funds to access a concierge physician who is able to provide these services is really difficult. And as far as the resources, there are not many physicians out there who actually do provide these services. So even if you do have luck in finding someone, you may have a 2 or 3 week waiting period to get in for that first visit. Now keep in mind, that's a 15-day waiting period from that first visit, and approximately 26% of patients will die within those first 15 days. So there's a real barrier there. And that's what the timing is. That 15 days is this safeguard that has been put in place to ensure that your request for aid and dying is consistent across time. So 15 days later, you're asking for the same thing and still understand what you're asking for. However, that timing is really difficult for patients who are terminally ill, and many of which, as I mentioned, will deteriorate rapidly within those 15 days and die. But what I want to discuss here today is really policy. Now, when we're talking about policy, I am often more commonly referring to policy that is established in healthcare systems as well as in hospices. And it has been my experience that there are 3 different types of policies that are out there. There is an explicit policy that says, yes, we do provide these services. This is a conscientious practice by our providers. They are entirely up to them whether they want to participate or not. We don't require them to. Or you have an explicit policy that says, no, we are a Catholic health system and we don't do this, and our providers don't do this. And as long as they are employed by us, they will not participate in this. But it's explicit. Everyone knows what they're doing or not doing. But there are obscure policies out there. So there are policies that some hospice providers have that say you cannot talk to a patient about medical aid and dying as an option unless they explicitly use the correct term. So they cannot say physician-assisted suicide. They cannot say euthanasia. They cannot say, I just want to put an end to it really quickly with a pill. Surely there's something I can do. They must explicitly use medical aid and dying as a term in order to access that option. And these are policies. There are other obscure policies such as with hospice providers, yes, you can pursue that, but our nurse cannot be in the same room while you take that medication. They must wait outside, down the corridor while you do that. So very unusual, glitches that sort of that are difficult to interpret and really cross the line as far as what is honoring a patient's autonomy and what is not, and how do we really handle this. But in my opinion, the worst is no policy at all. And this is what we see probably 80% of the time, is hospices or healthcare systems who do not have a policy on the record. which means that any sort of bias can come into effect with these patients, and they are subject to the whims of whoever is with them. Again, there's a lot of misinformation. So those team members that they're engaging with may not know that this is an availability to them. As with this case that I just mentioned, this nurse was taken aback by this option that the patient had pursued. And I think that this policy whatsoever is a disservice not only to patients and their loved ones who are looking to pursue this and don't know where they stand with their provider, but I also think it's a disservice to the employees or the team members of that organization who haven't been provided education, who haven't been provided with any sort of guidance on how to deal with this and end up getting caught by surprise and feeling great moral distress by it. So again, about 80% do not have a policy at all. So much so, this has been a problem that in New Mexico, when they passed their law, part of their law was that each hospital, organization, and each hospice has to publicly declare their policy online so that patients who are accessing it know exactly what they're getting into and what that provider will be able to service them with. Ethically, again, we have this issue of autonomy. This is a legal valid option for these patients. They have met the criteria. And, are we really placing undue burdens on them when we don't have a policy or we have this obscure policy that really makes it very uncomfortable, if not impossible, for them to pursue this option? And then we're talking about trust with a healthcare provider. And I think trust and that trusting relationship is incredibly important between any medical provider and their patient and their loved ones. If you don't have transparent and clear policies, how is that impacting that trusting relationship? And what is your agreement of care? We will only care for you as long as you don't pursue aid and dying, which is your legal right. And what is the responsibility of that employer to their team member? We're not going to provide education about it. We're going to employ a don't ask, don't tell policy with our patients. But should you encounter it, you're going to kind of be on your own and try to figure it out. And then we'll just figure out what we're going to do at that time if we don't have a policy. So I think trust goes both between the medical professional and that patient who's pursuing this option, but also that organization and their team members. It's really important that they are being protective and really providing their team members with the right resources to discuss this. What is the professional responsibility? Each nurse and physician has a code of professional ethics. Does that conflict with the obscure policy that tells you have to wait around the corner and not attend to your patient if they're choking or if they're in distress? And what about informed consent? And I think I'm going to get a question about this later, but what is informed consent? Are they really giving patients all of the options that they have? You can continue to pursue treatment, you hospice, you can have palliative care, but how many of these organizations are actually saying, and in your state, medical aid is dying and legal, if you should wish to pursue it? I would say probably less than 1%. And so informed consent, do these patients know all of their options or not? Referrals have been a problem. Sending records has been a problem. And I think we've seen that in the media as well. For providers who just do not believe in medical aid and dying, they will either not refer them to the right resources, they won't release their records. Again, an additional burden on those patients who are trying to pursue it. And of course, all of this creates a huge issue of moral distress. The abandonment that the patient feels at the end of the day, facing potentially having 911 called, having police show up at their house after they've pursued this option, knowing that their hospice provider that they've worked with for 3 months is just now going to leave them, and creates a real sense of abandonment. But what about the team member who also hasn't been prepared, who doesn't have a policy or doesn't have education to go by, or that wants to have conscientious objection? What methods have been put in place to help them so that they do not feel compromised or they do not feel that they are inadvertently participating in something that they are not comfortable with or not in agreement with. So a lot of moral distress as well. Again, all of these issues are very challenging for the patient, their loved ones, but also challenging for medical professionals. Majority of our cases are fairly straightforward. We do not have very often that bridge to MAiD. That issue with the anorexic patient is very uncommon as well. I do think that they present challenges and real difficulties in how we're going to expand this law or not. But the majority of patients are very straightforward. They meet the criteria, and we help to get them connected with organizations who are supportive of their options. And for those patients, the options of aid in dying are real and very, very important to them and to their family. I'm just going to show this video really quickly to give you an idea. Sorry, I don't remember how to get to the last slide, which is really just the question slide. Thank you so much. Sorry, thank you, Karen. There we go. Thank you so much, and I'm going to open it up to questions.
Okay. Thank you. All right, thank you so much. That was outstanding. Very, very helpful. So I want to encourage folks to raise your hand if you have a question, and a mic will come to you. We are obviously doing this online. We have over 200 people in the webinar, and we have some questions that have been registered, but I'm going to take moderator's prerogative and begin by asking you a question about the requirement for self-administration. And I'm wondering here about patients who have terminal illnesses. that actually preclude them from having the physical control to administer the drug. And, we can think about what those conditions are, but how do you think about that? And actually this question around, is this a form of discrimination in terms of the ADA Act, or how do you think about that as an eligibility?
It is, it's a very interesting question, and one that we have had much discussion about. So if you consider a patient who has ALS, and so they have diminishing physical capacity, their swallowing might be disappearing. They're not able to swallow. They may have a PEG tube, a feeding tube, and be unable to depress that plunger to deliver the medication to them. What are their options to actually access MAiD? Well, you may or may not be surprised that's the second highest category of patients who utilize MAiD is actually patients with neuromuscular issues, predominantly ALS. And for these patients, they very often have to utilize MAiD well before they're ready to, because they know that their ability to physically self-administer is diminishing. So very often they're actually doing this much earlier than they would want. Now, there is a suit that was brought against the state of California's law for aid in dying, suggesting that by forcing people to self-administer physically, we're discriminating against those individuals who otherwise would qualify for this. And is that really a violation of the ADA? The courts did not agree, but I think it's still up for debate. Are they given same access to medical care and options that other patients are, or are they denied because of their disability?
Okay, thank you. All right, so we would like the mics to come down, and I think there's a question here on the aisle.
Hi, my name's Clara. Thank you for your talk. I was wondering if you could speak a little bit about the status in New York. I believe it's been tried in the New York Senate a couple times. I was wondering if you could speak about the current status of that.
Well, I do not live in New York. I do follow it a little bit. I am not deeply involved in the legislation. I will say it took 7.5 years in New Jersey. And we were really hoping New York was going to do it in 2024, and they didn't pass it, which is unfortunate. It is a topic that has very strong opponents as well as advocates on either side. And sometimes I wonder if it's just the right perfect storm to get it passed. But there are others here that are involved in legislation in New York that will perhaps be able to give a better idea of it. I think it's still a battle.
Okay, great. All right, I'm going to take two questions from online. The first is from Dee Dee Sanchez. And she asks, for minoritized patients who already struggle to access basic palliative and hospice care, MAiD may not be a true choice, but rather a reflection of continuous healthcare neglect. If we acknowledge that access to MAiD is primarily available to some and not all, and I think you actually showed that in one of your slides, what point does the lack of accessibility at what point does the lack of accessibility become an ethical failure rather than a legal limitation? Should policymakers be required to address inequitable access before expanding MAiD?
So it is an absolute problem, and it has definitely been a problem with MAiD, the history of it here in the US. As I mentioned, white, affluent, well-educated people are accessing this. Part of the problem is that you need to have resources to a provider that you can actually access and ask questions and understand. And sometimes those minority or disenfranchised groups do not have access to it. So how are we presenting this as an option to those individuals at the end of life, or are we not presenting that to them because we're concerned that we're coercing them to end their life as opposed to pursuing additional treatment? So there's a lot of aspects that are very complicated with this, a lot of providers. There are concierge providers out there who do provide these services, who are easily accessible online. However, their services are thousands of dollars. And if you're at the end of an illness where you have perhaps, raked up many, many bills, another $6,000 or $7,000 is really a barrier that you cannot cross if you are not able to afford that. Even the medication itself can be very expensive. So there are organizations out there, there are advocacy groups in different states that actually have funds that help offset the costs for patients who wish to pursue it, but for which the financial burden really prevents them from doing it. I think it's going to be a very difficult, long road to make sure that this is an option that is accessible to all. The education's just not out there, the access, the sense of bias, the cost of it is unfortunately, in my opinion, going to continue to perpetuate a certain class of individual who is really accessing this.
Yeah, and I think her question is whether or not it actually should be allowed, given that we know that inequities are built in. This is not unique to this particular topic,
Right.
but it is an interesting question.
Mm-hmm.
So I'm gonna read the next question online just so that we get some of the nuance. This is from Craig Blinderman. And he writes, something that is often not entered into the moral calculus and would be helpful, at least from a utilitarian perspective, is the impact MAiD has on families and loved ones. Anecdotally, I have heard from family members and other clinicians who have mentioned that loved ones and caregivers, quote, go through the process, end quote, and say something like, quote, whatever dad wants, I will support it, end quote. And then in the end, have deep regrets and wish they had pushed back a bit more and had more time with dad. I wonder how we can account for this perspective and get better outcomes data to ensure we are not creating more suffering.
Interesting question, because it has not been my experience that has happened. We have had patients where the family or loved ones was actually not supportive at all and just sort of begrudgingly started the process with them or helped them with it. By the end, after they have experienced the passing of their loved ones, you very much get those quotes that I played in that video. Those are actually all patients and all family members. There is a challenge, though, that is particularly unique to loved ones who are helping their father, their mother go through this, that this is somewhat of a double-edged sword. They want to be able to honor their loved one, provide this last option for them, but they know that this is going to take them away from them much earlier. They also have the stigma involved with it, so they very often are not talking to other people about this as an option or that their loved one passed in this particular way. So I think that stigma can really create even more of a problem. To that end, there are bereavement programs out there that specifically target loved ones whose father, mother, brother, sister, wife have pursued MAiD, because it is a unique experience for them. There have been studies that have looked at sort of the grief process for families after the fact. And although it is a deep, natural grief, it is not complicated. And, study after study has shown that this is not complex, disenfranchised grief that they're experiencing. And I would say in some ways, these families know exactly what their loved one wants. They have had very robust discussions with their loved one about what's important to them and how they would like to end their life. So there's never a question of, did I do the right thing or not? Because they are honoring their loved one. But it is different. It's a different grief process. The majority of the world, nobody wants to talk about death. These patients are planning it.
All right. One question down here.
Thanks to both of you for creating this conversation. Sandra, a follow-up to your question about self-administration. I'd be interested in both of your perspectives on A, why intravenous administration can't be one of the routes of self-administration, and whether that reduces the number of patients who are not able to self-administer because they are so advanced in their ALS or other neurodegenerative diseases.
I'll let you go.
So interestingly, this topic has come up among some of our listservs. 11 jurisdictions that have MAiD as part of their law. Only 3 of those do not specify what self-administration looks like, and that's New Jersey, Hawaii, and Vermont, I believe. They do not specify what self-administration looks like. All of the other states are very clear that it's going through the GI tract, that the patient must either drink it, depress a plunger, either through a PEG tube or rectal catheter. So they're very clear about it. However, for these other 3 states, they are not prescriptive about it, but they haven't done it through an IV, which begs the question, is it just an understanding that this must go through the GI tract, that is the only way that it should be administered? And should they be exploring other ways, such as setting up an IV that the patient is able to activate in some way or another? Again, I do not believe that we will ever have euthanasia in this country where we have a provider that is actually physically delivering the substance that's causing the death of the patient. I think it will always require some voluntary action by the patient to initiate that. But IV use has not been explored. And I don't know whether it will or not. I think it's something that is a very good discussion point.
Yeah, so I think this is a great question. And whether or not it's because we feel that providers should not be involved at all, it's a hands-off kind of activity, or if it's more of a demonstration that one is exercising their autonomy, and that's one way to show that they are. I'm not sure, but it's interesting. Betty Levin online has a question that's related to this, because in Canada, of course, the patient isn't required to self-administer. And we've been hearing all kinds of things about what's happening in Canada. I don't know if you can comment on the differences between the US and Canada and how things have shaped up in terms of any kind of outcomes data. Yeah.
Definitely, there are very stark differences between here and Canada. In Canada, it has actually been enshrined in the Charter of Rights. So it's not a law, it's a right of a patient to be able to access aid in dying if they are suffering interminably. They also have 2 tracks, one for patients who are terminally ill within 6 months, and then 1 track for patients who are just suffering. So like the patient who had, unremedial diarrhea following all of her surgeries and was just suffering. So they do have that. I think the biggest controversy that we're hearing now is that Canada is going to open this up to individuals who have psychiatric diagnoses and no terminal condition per se. And it's difficult because I think Canada has backed themselves into a corner by saying this is your right. This is your right as a person, as a citizen of Canada. If it's your right, how can you deny this from certain people and not others? And they keep pushing that date back. They were supposed to allow that, I think, in 2024, 2025. They're just not ready to be able to provide that option to patients. So they've pushed it out to 2027. I think for the majority of providers in Canada, it's a really uncomfortable concept that they would be providing this option to patients with a psychiatric diagnosis. And then also in Canada, as you mentioned, there is the option to either self-administer or to have this administered by the healthcare professionals. And as you can imagine, about 99% of them are doing this with a healthcare professional and with an IV, which is just much more controlled and really takes the onus off of that patient or their family of trying to figure this out or do this on their own, and in many ways much more humane, I think.
Okay, let's take one more question up here.
Thank you. Thank you for this talk. My name is Eve Slater, and I'd just like to posit a few reflections from the physician's point of view. Actually, just a couple of technical things. More than 90, you're correct, more than 90% of the deaths in Canada are now by euthanasia, so directly administered by the physician. Have there been any studies, I guess a question, we're not going to be able to answer it in time, but on physician remorse, noting that, for example, in as many studies as I've been able to ascertain, fewer than 50% of diagnoses, terminal diagnoses, are actually correct. We get it wrong more than 50% of the time in terms of 6 months. Secondly, with increased fragmentation of care, how well does the doctor or the professional, the practical nurse, know the patient before they're in fact required or requested to prescribe the lethal medication? And lastly, I just don't think we can have a fair discussion of this topic without further delving into the slippery slope. We need to see those numbers much more clearly, I think, than were presented today, even though you did make some effort to give a balanced presentation. Thank you.
Let's start with the prognostication question. I completely agree, and there is lots of evidence that is out there that says we are pretty bad prognosticators. And definitely we do see that with patients who have been qualified for MAiD, who get their medication and are still alive 2 years later. So there definitely does happen. The second question you had, I'm trying to remember now.
The slippery slope?
The slippery physician. Yeah, so the physician regret, I am not aware of any studies that specifically address a physician's remorse in participating in it. I would say that it is most important, if you are a physician considering this, that you are doing this conscientiously according to your beliefs and your values. And I do not believe that any physician should be, forced or feel that they have to participate in this for their patients. Having said that, the majority of physicians and the patients who pursue this are not going through their family physician, so they don't know them. The family physicians are not participating in this. Many oncologists are not participating in this, or neurologists. So these patients, for the large percentage, are actually going to someone brand new that they have not met before. And how well do they know this patient? Well, they haven't known them for years, but they are looking through their records. They have very extensive conversations with them. Those visits usually last an hour and a half, and there's 3 of them that they're going through. But it is not their personal family physician who is generally helping them with this. And when you look at the requirements for actually participating in MAiD and the paperwork and what you have to cover and document, it is a huge learning curve. And I am not surprised that for those physicians, even if they wanted to, would be discouraged because of the learning curve. So yeah, I would say the majority of these patients, probably over 90%, are going to a physician they have never met before.
Okay, well, we have so many questions and so little time, but thank you very much for your presentation and for your questions. We do have lunch available for those of you who are here in person, and I'm sure Yvette will stick around for you to discuss your questions with her. All right, so the recording of this event, as I mentioned before, will be posted on the Columbia Division of Ethics website. You'll be getting an email with the link. The next grand rounds and the resources will also be available. Let me go to the next grand rounds will be next month, Tuesday, March 11th at 12 p.m. in this room, where we'll be joined by Doctors Talia Portney from the Health Policy and Management Department in the Mailman School of Public Health here at Columbia, along with Eunice Rendon, who's the Executive Director of Agenda Migrant. And they will be in discussion about migrant health in the context of deportation. Please subscribe to our mailing list to stay up to date with these events. And finally, to those of you who are joining in person, you have a survey that we really hope you will fill out. We take your comments seriously. It really does help us in terms of planning these events. For those of you who are on Zoom, there is this QR code that I hope that you will be able to access our post-event survey. And then thank you again for coming, and we hopefully will see you downstairs. And for those of you online, I hope to see you in March. Thank you.